enter the room.
Hello, Dr. Mukhopadhyay. Are you Jessica Lambert?
Yes, I'm Jessica Lambert.
All right. Are you related to Andrew?
Yes, my son Andrew Lambert
All right.
is here with me.
Okay. Can I please confirm his full name and age, please?
Andrew Lambert, and he's 18. 18 months. Yeah, just
Okay,
18 months.
18 months. All right. Thank you so much. Is it okay if I call you Jessica?
Yes, you can call me Jessica, doctor.
All right. Thank you so much. Lovely to meet you, Jessica. What brings you in today?
Doctor, I'm a bit worried about my son, Andrew. Andrew has not been, he's been crying uncontrollably in the last 10 hours, and I'm so bothered about it. That's why I decided to bring him down.
So let me confirm, he has been crying for the past how many hours?
10 hours, doctor.
He has been crying non-stop for the past 10 hours. I understand that must be frustrating. Could you, can I ask you a few more questions to understand why that may be happening?
I have no idea, doctor. That's why I decided to bring him.
Okay. So, could you please tell me if he's been eating and drinking properly?
He's not been eating well, and he's just not drinking well as well.
Okay. And would you say it started in the last 10 hours?
Yes, last 10 hours, that's when all of this has started. He's crying, the pattern of crying for 5 minutes, and then again he pauses for 1 minute, and he starts crying again, and that's be troubling me, doctor.
I see. I understand it can be quite difficult. So has he been passing stool and urine?
Yes, doctor. He does pass too, and he passes too, doctor. Yeah.
Okay. And does he seem to be in pain? Is he showing any signs of pain? Is he pointing to his tummy or anything of that sort?
That's difficult for me to tell, doctor. He's just crying. That's all I know. He's crying uncontrollably, and that's it. So if it's the pain, it's very difficult for me to know. It's just 18 months, doctor.
I understand it can be quite difficult to see him crying and not knowing the cause. Can I ask you a few more questions?
Sure, that's why I'm here.
Okay. Yeah. How was his birth? Was there any complications?
Bed is fine. He has no issues with bed, doctor.
And had he been eating and drinking and playing with his toys before this episode started?
Yes, he was generally fit and well until the last 10 hours, doctor.
Okay. And was he diagnosed with any long-term conditions?
No, that's fine, doctor. He has no issue with long-term. His bed is fine. Immunization is fine. Development is fine.
Okay, I understand. And could you please tell me if he has any siblings?
He's got siblings, and the siblings are also fine, doctor.
Okay. And okay, I'd like to examine Andrew. He's in the other room with the nurse at the moment, and I will get back to you. Yes. So I'd like to check his vital signs, like his blood pressure, his heart rate, his oxygen levels, and also an abdominal examination where I'd like to listen to his abdomen as well, and palpate means press to see whether he reacts to the pain. Also, I'd like to listen to his chest as well. Okay, so Jessica, from what I've seen during the examination, he seems to be very pale and lethargic, and his pulse rate I'd say on the higher side, but it's not alarming. But on his abdominal examination, unfortunately, we found a sausage-shaped mass, which can cause these symptoms because it is a condition that causes pain in young children of his age, and they often cry to. It's
Doctor,
called.
is this serious?
I'm sorry, but before I go on, would you? Is there anything that you would like me to do for you today?
Is this serious, doctor?
It is serious. It is called intussusception.
2 minutes remaining.
And it is basically caused when there is intestinal obstruction, as in there is the mass is not allowing the food and the water to pass through his stomach. So what we will do at the moment is that we will admit him and run a few tests, like a USG and a CT scan.
What is USG, doctor?
So USG is a scan technique in which they use ultrasound waves to understand how the organs are looking. So we will look at his intestine through that.
Oh, I see. Will you admit him, doctor?
Yes, we will admit him now. Like I said, run the tests, and then we will try a non-surgical way to fix it with air enema to put the bowel back into place. Or if the intestine is unfortunately torn, we might have to do a little surgery with laparoscopy, in which they make little holes.
Okay.
I understand it's a lot to take in, but you've done the right thing by bringing him in. I'll also give you this leaflet so that you have an idea about what's causing all these symptoms. Also, I'd like to tell you that if he develops any symptoms like profuse vomiting or dizziness, or if he feels faint, just let the staff know immediately and we'll be there to help.
Oh, okay, doctor.
Move on to the next station.
Oh, okay.
Good job, Dr.
Thank you so much. No, I went clueless. I went like very in the middle. It always happens. But I think it's going to get better with practice. I don't know why I lose, the track of thoughts and my
But
words.
I think
Just at the beginning of your preparation, I guess.
Not exactly beginning of my preparation, doctor. It's I have my examination on 30th April. Like, I'm usually good when I'm practicing alone or one-on-one, but whenever I do it in front of people, I don't know why I've got this anxiety.
Oh, don't worry about it. I think, Dr. Devlin, you're doing great. Just that one thing I feel that when you are put on the spot to actually deliver medical in a more layman language is something that you're actually struggling with. So explaining intussusception, explaining USG, I think you know what you're actually looking for, and I think you know what you want to say. But when it comes to the ultimate delivery,
yeah, I can't find the right words for it for some reason.
Yeah, but that's all right. Think of it in the most simplest way. I mean, USG, you can just say that we will use a modality where we can have a better look into your son's tummy. Keep it as simple as possible. Because you don't have to explain the ultrasound waves and everything like that. That's for us, right? They don't need to know how it's done. So if that's the case, how are you going to explain an MRI?
Oh, exactly.
So you'll have to be as simple as possible. I mean, even an X-ray, just to it'll be a radiation where structures that are abnormal can be seen if misplaced, right? We'll get a better idea by looking at what's inside, you know. It helps us to visualize what's inside. That's it. You know, keep it as simple as possible, because you're trying to tell them what is the next step, right? And the next step for you is an investigation. So technically that's what you're telling them. I'm going to be investigating to make sure, you know, it correlates to what I think it is. Because you examine it, you feel it is intussusception. Now you have to confirm it. And so that's what you're doing, right? Because this is an emergency case. And because it's an emergency case, you have to treat it like that. You need to admit him. What are the things that you're going to be doing though?
So the first thing is admitting and seeing whether he's stable, providing IV fluids and painkillers,
Absolutely.
and like trying a non-surgical decompression or reduction.
Right.
If that fails, then we go surgical.
Absolutely. I mean, I think you brought in the whole fact of perforation way too soon. Like perforation will always have its own sign. You will have peritonism and everything. Right? It doesn't look like it's perforation. So don't bring in unnecessary information when it's not needed. So when air insufflation fails, then you try for a surgical reduction. So what exactly is, what is this intussusception? You mentioned something in lines of a tumor.
No, basically it is the telescoping. I wanted to use telescoping, but I thought, oh my God, that will make it more complicated. Like
something that we all know.
So the intestine basically invaginates.
Or you can say slide.
Use those words.
You can use the term slide, that one part of intestine slides into the other.
There you go. That's so simple.
Yeah, because that exactly sounded like a tumor, because you mentioned that there is a mass which is blocking the food to go through that intestines, and that sounded like there is some mass in the intestines, which is actually not.
Okay.
Yeah. So a couple of things. That's one thing. Do not give wrong information, because in this case, adding on the mass is unnecessary. Right? It's kind of driving you away from the real diagnosis. So keep it as simple as possible. Think of the most simplest way you can explain it. And thank you, Dr. John. That was a great simulation. And when Dr. Devlin brought up the USG, you definitely made sure to ask what that was. That was good.
Yeah, thank you.
Like, if you're going to throw jargons, make sure you follow it up with an explanation. If you're going to use the words USG, explain what it is. You know, take some time to do that.
All right. So examination findings, it is mentioned sausage-shaped mass. So maybe she used the term mass for that reason. But this just means that on examination, it felt like there is a mass, but actually there was no mass. It was just a sliding of intestines.
Yeah. I mean, I think you found out that it was intussusception. So, you know, the most layman way of explaining what it is. So I'll hand it over to Dr. Sana. So Dr. Sana, the stage is all yours.
Yeah, I have submitted the checklist as well, Mark. And yes, starting from the beginning, the main thing which I found was like, Dr. Devlin, your speed was a bit slow to complete a case in an 8 minutes time. So you could be a little bit faster with the Socrates thing and the red flags, associated factors, everything. You could have been a little bit more faster so that you can do your data collection in timely and then go towards the management. And it was only 2 minutes remaining when you started the management part, which was actually long as well. So this doesn't allow you to complete the station in the given time.
Okay.
Yeah, and another thing that in the beginning, you are supposed to ask that is the child here present here with you in all the PED scenarios, because you cannot just assume that the child is with the nurse or I'm going to examine that child and then I will be coming back. You just need to ask that to parent, that is the child here with you. If this parent says that the child is here with me, then you go on with your examination.
I'd like to intercept. I think it is mentioned that the child is in the room. So I think Dr. Devlin used the information from the candor information. But yes, definitely. Do ask that question if it's not mentioned.
Yes.
Sorry to
Yes.
interrupt. Go ahead, Dr. Sana.
All right. And like you confirmed the patient's name, age, that was fine. That was very good. And you also acknowledged the mother's emotions as well. That was also very good. Regarding the crying thing, you took a good history that for how long the child has been crying, the episode 1 and those things as well. But the stool, you didn't actually ask about other systemic signs as well, maybe anything related to the other systems of the child, because the child was too small and we need to do a sort of systemic review of the child as well. That are there any issues with the other systems that might be causing any sort of crying or discomfort to the child?
Mm-hmm.
All right. And regarding the tummy pain in a child, we usually, in a very little baby, we usually seem to ask it that is the child pulling the legs towards the tummy, because
Mm-hmm.
the child may not be able to mention that I have tummy pain. So that these are some of the signs. For ears, we can use that there is the child pulling the ears, something like that.
Mm-hmm.
Okay.
Okay.
And apart from that, you could have explored the stool thing more when you came to know that the child is having some tummy pain. You could ask about the stool, color of stool, any vomiting. I think you asked vomiting, I guess. But any sort of presence of fever and any sort of associated symptoms as well.
Mm-hmm.
Okay, and to be very much concerned, especially in the pediatrics cases, whenever we find out any sort of vomiting or any sort of diarrhea or any stool disturbances, we always look for signs of dehydration as well.
Mm-hmm.
Okay, so that we can see that due to the vomiting or such things, is the child being dehydrated, or is it okay? So that accordingly we get the alarming sign that we need to admit the child or start the child on fluids or anything like that.
Okay.
All right. So you asked about the feeding status, that is the child feeding normally and fluid intake. That was completely asked. And regarding the examination thing, I think you forgot to order the lab investigations. You did.
Oh, yeah, doctor, because I was sort of rushing towards the end, so I figured
Yeah,
out, especially
that
after the
sounds
USD question.
yeah, but you forgot to order any blood investigations, so you were in a
Yeah.
thing. So you could have done all of these investigations at a
I,
time.
I just, I just want to add one thing. But
Yeah.
why is the investigation so important? Why do you think, Dr. Devlin, the investigations would be so important in this case?
Like in this case,
Mm-hmm.
to see electrolyte imbalances, especially hyperkalemia.
Hypokalemia.
Oh, sorry, yeah,
Child is
hypokalemia.
vomiting, right? So
Hypokalemia.
any chronic
Mhm.
vomiting, first thing that should come to mind is dehydration and electrolyte imbalance that can actually cause almost imminent death with even the slightest ranges of electrolyte imbalance. It could cause heart arrhythmias, right? So definitely goes up because you need to correct them immediately. Even before surgery, you'll have to correct them.
Mm-hmm. Okay.
Yeah, and when doing the FBC, we can also look for any signs of infection if there is some other diagnosis underlying.
Okay. So I'll make sure to include the investigations, the blood investigations before the USG scan.
Yeah, when in the management part, when you are ordering the ultrasound, you can mention the blood investigations at that time.
I have got a question, doctor.
Yeah, go ahead.
So when I tell them the investigations, do I have to make sure I tell them in a simple way, or do I just say that, okay, I will do blood tests like U and E, and I would like to also check FBC?
Instead of saying FBC, UNE, you can say that I would like to order some routine blood investigations to check for any sort of infection or electrolyte, or instead of electrolyte, you can say salt disturbances in the body.
Okay.
Okay, just some routine blood investigations to check for any sort of underlying infections or salt disturbances in the body.
Okay, so I can just say that I would like to do a couple of blood tests to see whatever the concern is, like whatever it might
Yeah,
to-
to understand
Mhm.
any sort of underlying issues or any infections, any sort of salt disturbances in a simple way. Something that
The
they
general rule, sorry. So the general rule is whenever you're ordering an investigation, back it up with why you're ordering it.
yeah.
If you're looking for electrolytes, mention that, because the person who hands you these investigation is the simulator. So unless he hears that word of what you're looking for, he will not hand you the investigations at all. Right. So say that I'd like to do some investigations to look at the electrolytes in the blood for any infection markers. Right. I mean, even
Okay.
though you said I'd like to do some investigation to look for some underlying cause, that's very general. Give
Yeah,
it,
that would become very
back it up.
general. Yeah.
So yeah, definitely
So,
back it up with your thought process.
yeah, the patient should also know that what you will be looking for in that investigation so that he knows that why they are important. Okay, so regarding the scan as well, you can also mention that we will be doing that instead of ultrasound. Ultrasound is something which is understandable to most people, but you can use some simple term is the scan, which is the most simplest term. So you can say we will be doing some ultrasound scan, which is to look for any sort of tummy issues. Okay.
Okay.
All right. So there were some symptoms which were partially covered. So regarding the PMFTOSA thing, yeah, this wasn't completed, which we usually take the history in the children, the allergies, vaccination history, and those sort of stuff. These questions were kind of thing.
Mhm.
And the associated factors as well, those were also not completed. You could have asked about more symptoms, about the dehydration symptoms, all of those stuff. Those could have been asked more. And regarding the management, the basic things were kind of missing. The basic things were like, you did the admission thing on when Dr. John asked that, will you be admitting me? So you said that, yes, I will be admitting you. Another thing which you have to do, you have to involve the seniors as well, which is very important. Because the seniors will be taking the decision of any further surgery, air enema, or the further management thing. Okay. Because
Okay.
you are an FI2, you wouldn't be taking the decision of surgery yourself. So you will be involving your seniors, you will be involving the surgical team. You can mention something like that. And you have to tell them that in case there is like a possibility that a surgery might happen. So you will be keeping the child nil by mouth and starting the child on some IV fluids. And you might also have to insert an NG tube. Okay.
Okay.
And the child will be kept in constant monitoring thing as well.
Okay.
Vital as well. Yeah. Okay.
Mm.
And yes, the ultrasound was done. Prepare for air enema. Explain possibility of surgery. Yes, these all things you have kind of explained. And you could also do the safety netting as well. That because in an admitted patient, you can also safety net the parents that what are the worst things that can happen, so that you can ring the buzzer and call somebody in the staff so that they can come and see you.
Okay.
Okay, so if the situation worsens, if they feel that something is not right, or if the child like having worsening pain or something, so they can call you. And you also forgot to give any painkillers to the child.
Yes, IV fluids and painkiller. That's the part I missed.
Even before the surgery thing, the painkiller is actually very important because the presenting complaint was pain. So you just left the child with discomfort and pain at the end of the station as well. So try giving the painkillers in the beginning of management part.
Okay. And I've got a question, doctor.
Yeah.
So, when I ask, like when I tell the patient no, the patient's mother that I'm going to put him nil by mouth. Can I just use nil by mouth, or should I say that he won't be allowed to eat or drink anything, but we'll
But
stop
okay,
immediately?
he won't be taking anything by mouth. You can
Oh.
say it like this: he won't be taking anything by mouth to in case because we might need to go for surgery.
Okay. Okay.
Nail by
Yeah,
mouth is something. Yeah, go ahead,
Yeah,
Dr.
I would actually concur with Dr. Sana in that. So whenever you're explaining something to the patient, don't try to use jargon that, is more recognizable by us.
Yeah.
Just say that we would be avoiding any feeds from here on, just to prepare ourselves for the possibility of surgery. I can mention it like that.
Yeah,
Okay.
because doctors
We're actually talking to the mother.
use in routine like nil by mouth, but to a layman, he might be listening this term for the first time, nil by mouth, and he will be asking you question that what is meant by nil by mouth, and it will waste your time further. In the exam,
Okay.
it will ask you that what is nil by mouth, and then you will start explaining nil by mouth means that you will not be taking anything by mouth, and that will like cost you your time. So it's better to use the simpler language first so that you do not get interrupted by the patient or the simulator to explain it further.
Okay.
Right? Just like Dr. John interrupted you to ask that what is USG. So you had to tell him that what is USG. So it actually took your time.
Okay.
Instead, you could have used simpler language first and it could just continue with your consultation.
Yes. Yes, doctor. I understand.
Okay. Yeah, so that was all from my side. And the main thing which I noticed was you could utilize your time by speaking a little bit faster. So you can cover more points and complete your station within that time.
Okay.
Okay, and the major thing was the explanation of that interception thing, which actually looked like you are explaining a tumor. So just try to avoid such mistakes that the examiner thinks that you do not know what is interception or you are just trying to make some different diagnosis. So that can also cost you a lot of marks.
Okay. Okay. I understand, doctor.
All right. So yeah, that was from my side, Dr. And if you want to add anything, you can tell.
Absolutely, Dr. Sana. That was very thorough. Thank you so much. So as a treat for everybody who is on the call, we have created a textbook of sort, which we are planning to share with everyone. This is all the studying that we have done for PLAB 2 and the subsequent exams. And we've tried to, we've touched upon a lot of topics. So it's a very simple to use app and it's completely free. One thing you guys must know about PLAB 2 is that it's not testing your knowledge, but that doesn't mean you can go absolutely wrong. If you don't know something, the best thing is to admit to that fact. Say that at this point, I'm not sure, but I will be consulting with my seniors to find out what could be the underlying problem. But to be a safe doctor, make sure you keep them in the hospital until that consultation is done, right? So that is one way that you can actually tackle scenarios where you don't know the diagnosis, right? So again, reiterating on that fact, PLAB 2 is not an exam which tests your knowledge. However, it's the delivery of your knowledge that you are trying to explain to a patient. That's what is really important. But as a side note, we have created this textbook where if you are confused about a certain case and you want to look up a little bit more about it, you can check out this textbook, for which I'll be posting the link on the in-call messages. And this is something that we are only giving for the people who are attending our calls. So for anything that you want to look for, you can go to the search bar, type in what you want to look, and it will give you an option of where all it's located. Like if you want to talk about vomiting, type the word vomiting and you will be seeing all the places where vomiting is mentioned, right? I mean, vomiting is a little more general. If you want to talk about something more specific, say subdural hemorrhage, you can see all the places where it would be mentioned so that you can quickly take a look at what are the important points related to that, but don't spend a lot of time learning new things. Use the knowledge that you have. We have made the workbench in such a way that it gives you the information of all the cases and what is related to the cases in it. So I've posted the link for this textbook. So if you guys do want to refer, and if you feel that you don't know a topic very well, you can always refer to this and check it out. Yeah. So a couple of things about intussusception. So this is a condition where basically you will be, as very correctly pointed out by Dr. Devlin, this is the age group, like 6 to 8 months is the age group, the median age group where this condition is most likely to occur. And in our scenario, this child was 18 years old, so it was actually within that timeline, right? So you actually have a high suspicion of intussusception if a child in between 6 to 18 months comes with unconsolable cry with abdominal pain. So this type of pain would be a colicky pain, and a very classic sign would be, the child would be out of the pain. He or she would be, drawing up their knee to their abdomen. A classic fetal position. They'll actually have that fetal position. The stool is generally seen to be red currant jelly. That might actually come up in the conversation or in the consultation. Or if it's vomiting, it might be usually bright green. Why is it green? Any idea? What does that mean? Anybody?
Bilious vomiting?
Absolutely. So basically, it's after the DJ flexure, right? Or the opening of the bile in the duodenum, the second part, after the second part of the duodenum, right? So that means the obstruction is somewhere down there, like, lower GI. So you kind of get an idea that, all right, so, it is a lower GI cause, right? And other, high yield points is the sausage-shaped mass, usually located in the right lower quadrant, investigation of choice, and what you see in these investigations, but these are not very important. I am still reiterating that fact. You do not have to learn new information. Try to, put the information that you already have in layman terms. That is a skill that you need to develop for this exam. All right.